Okay, so the next talk is Dr. Anuradha, and she's going to talk about iridocorneal endothelial syndrome, our experience from a series of patients in a tertiary care setting.
A very good afternoon. Iridocorneal endothelial or eye syndrome is a spectrum of three overlapping conditions, which is a primary anomaly of the corneal endothelium, iris and angle, causing universally secondary angle closure glaucoma, and is seen to present commonly in middle-aged women. Today we present a series of 5 cases which include 4 women and 1 male patient. Our first patient was a 43-year-old female who presented with diminished vision in the right eye. Her vision in the right eye was 6/9, which was not improving further, and IOP with Goldman amblination tonometry was 36 millimeters of mercury. On examination, this patient had ectropion UVA with pedunculated iris nodules, and fundoscopy showed a cup disc ratio of 0.8:1. Visual field showed advanced field defects, which was corroborated with OCT RNFL. Anterior segment OCT showed synechial angle closure in all quadrants, and specular analysis showed reversal of cell borders with a central bright spot, which is pathognomonic of eye cells. So based on clinical features, this patient was diagnosed as a case of Cogan-Reese syndrome and was managed medically, failing which she was taken up for augmented trabeculectomy in the right eye. Certain special considerations were done in this patient: a longer exposure time, a slightly higher concentration of mitomycin C, and a larger sclerostomy was done after careful planning and proper counseling of the patient to achieve better surgical outcome. In the early postoperative period, this patient had a higher IOP and a flat bleb, which was managed with the removal of reversible sutures and ocular massage, with which her IOP was brought under control, and the bleb was adequate. The second patient was a 47-year-old male who presented with vision loss in both eyes. However, his vision was found compromised only in the right eye, which was 6/9 with no further improvement, and IOP was 36 millimeters of mercury in the right eye only. The anterior segment showed ectropion UVA, pedunculated iris nodules, and atrophic and stretch iris holes in right eye only. Fundus examination was normal in both eyes. Visual field showed few paracentral scotomata in both eyes, which were not fulfilling Anderson criteria. This patient was diagnosed as a case of Cogan-Reese syndrome of right eye and was managed with topical anti-glaucoma drugs. Presently, he is on maximal medical therapy. He has been counseled that he may require surgery in the future and is managed on with medical therapy. The third patient is a 33-year-old female who was a known case of eye syndrome and was referred for management of secondary glaucoma. Her vision in the left eye was perception of light with an accurate projection of rays, and IOP was 50 millimeters of mercury with total glaucomatous atrophy. Anterior segment showed characteristics of Cogan-Reese syndrome. In this patient, the primary aim was to salvage the eye and reduce the IOP, so the patient was taken up for transscleral diode laser cyclophotocoagulation after counseling of the patient regarding guarded visual prognosis. A 40-year-old female presented to us with diminished vision of the left eye. On examination, her vision was 6/18 with IOP of 28 millimeters of mercury. She had iridocorneal adhesions with microcystic edema and a beaten metal appearance, and no iris nodules. Visual field showed biarcular scotoma, which was corroborated on OCT. And anterior segment OCT showed synechial angle closure with pleomorphism and polymorphism and reduced cell density on specular analysis. This patient was diagnosed as a case of Chandler syndrome due to predominant corneal features. She was managed with YAG laser PI in both eyes, followed by topical anti-glaucoma drugs, and is presently maintaining her IOP in target range with medical therapy. Our last patient was a 37-year-old female who presented with glare and halos in the left eye. Her vision was and IOP were within normal limits in both eyes, but the left eye showed correctopia polychoria, and her fundus, visual fields, and OCT RNFL were also normal in both eyes. However, specular analysis showed pleomorphism, polymorphism, and a reduced cell count compared to the right eye. This patient was diagnosed as a case of essential iris atrophy without glaucoma and is presently on close follow-up with counseling without any management. So eye syndrome is now considered as a constellation of 3 entities: Cogan-Reese, Chandler, and essential iris atrophy, with major overlap between the 3 conditions. The etiology is still uncertain. Viral etiology has been hypothesized. It is said to be affecting middle-aged females. However, literature regarding this has been changing. The essential pathogenesis is a metaplastic transformation of corneal endothelium, causing an abnormal membrane which progresses onto the angle and iris, causing secondary glaucoma and iris changes. So in this case series, we encountered a male patient Also, in the 5 patients, we encountered different types and different stages of eye syndrome, and we were able to customize the treatment according to patient requirement. In 2019, Malhotra et al. Had published literature in which there was a male preponderance of up to 62% which was published, and they were also able to demonstrate 2 different morphology of eye cells by in vivo confocal microscopy, which could affect the prognosis and presentation of disease. Eye syndrome has also been seen to present bilaterally, which could be asymmetrically in the 2 eyes or as 2 different syndromes in each eye of the same patient. It has also been seen to present in the pediatric age group, which has to be managed surgically, or it could even be associated with certain syndromes such as Down syndrome. Predominantly, Chandler syndrome has multiple predominant corneal findings, while Cogan-Rees and iris atrophy have iris findings. The specular analysis shows reduced cell count with pleomorphism and polymagatism. The pathognomonic eye cells may not be seen in all cases. Visual fields OCT are used to see glaucoma progression. Management is tedious as this is a relentlessly progressive disease. Medical management is maintained to the longest extent possible. Corneal edema can be reduced using hypertonic saline and lubricants as well as IOP reduction, for which aqueous suppressants are used. And Rho kinase inhibitors are known to reduce IOP as well as improve endothelial functioning and morphology. Antiviral therapy is not recommended at present. Laser peripheral iridotomy is associated with high closure rates but can be used as a temporizing measure. Surgery, augmented trabeculectomy with certain modifications which have not yet been proved by literature can be used as a primary surgical modality, and glaucoma drainage implants are reserved for cases of failed trap because they are associated with slightly lesser chances of failure. Other surgical modalities under evaluation are Zengel stent and insulcus or pars plana implantation of glaucoma drainage implants. And patients with advanced corneal decompensation may require endothelial keratoplasty or penetrating keratoplasty with or without lens extraction. Transplantation of cultured human corneal endothelial cells are also under research. To conclude, eye syndrome is a progressive disease which universally leads to secondary angle closure glaucoma. At present, it has been reported to affect all genders, any age group, and the onset and progression may depend on morphology of the eye cells, as has been seen by in vivo confocal microscopy. Management is tedious. Patient counseling is very important to make them aware about the requirement of surgery and multiple treatment modalities and guarded visual prognosis. These are my references. Thank you.
Nice presentation. What will be the general surgical outcome of trabeculectomy in these patients?
Ma'am, generally trabeculectomy after a period of time, it depends from patient to patient the rate of inflammation, but it tends to fail with time because the pathology is progressive. So the sclerostomy tends to close, the iridotomy tends to close, and it can fail with time.
So one of the cases where we can go for primary tube.
Yes.
Ma'am.
So what is the role of PI in these patients?
Ma'am, PI again is sought with very high failure rates because the iridotomy
so
closes.
What is its role, whether you do or not? What is its role? It is
Ma'am,
not preventing PAs.
in 2 of our patients, in one patient, she had come with a prior PI. In the other, we had done it, but it was just as a temporizing measure while the medicines took their effect to reduce the IOP.
See, PI we will do only for pupillary block, mainly for pupillary block. How here it helps? I'm asking.
Ma'am, since the pathology is secondary angle closure, so
It is
Sorry, I will agree. I completely agree with you. That's the 2 concern I have. Never do a PI in these cases, not even a temporizing measure, because this is a uveitic type of a secondary glaucoma. So PI, in fact, is contraindicated in these cases. And I will be very keen to know how is your first patient doing with the trap. This case has got high success or high failure of trap, and completely agree. Primary tube is the treatment of choice. I'm very surprised that 3 of your patients still manage on drops because they are very aggressive glaucoma, and do a primary tube, never do a PI, and don't plan a trap.
Thank you.